Okay, so placenta previa, this is the placenta implantation by the lower uterine segment, which is going to be partially or completely covering the cervical opening. Occurs in about 5 in 1,000 pregnancies. Signs and symptoms of this were going to be painless, bright red bleeding, strongly associated with the number of C-sections and delivery that a mother has had. Most common cause of preterm bleeding. Preeclampsia. So this is the gestational hypertension after 20 weeks and at least one of the following is happening. So there's protein, blood and urine, proteinuria. There's impaired liver function, renal insufficiency, pulmonary edema, and visual cerebral disturbances. Severe HTN characteristics by systolic 160 and diastolic less than 110. Sorry, greater than 110. IV and oxygen are PRN, calm transport, abrupto placenta. So this is the partial or full detachment of a normally implanted placenta at more than 20 weeks gestation. Occurs in about 1% of pregnancies, results of fetal death in about 15% of cases. Signs and symptoms, the third trimester pain. There's going to be stabbing pain, painful dark red bleeding, localized uterine tenderness. Preeclampsia, this is the seizure and eclampsia. So with tonic-clonic activity, we're going to have grand mal seizures, and we're going to have left lateral recumbent positioning that we want to give to our patient. So with this, we're going to have IV access in order to push drugs whenever needed, and magnesium sulfate in this case rather than Versed or midazolam. We're going to give 4 grams over 10 to 20 minutes. We can consider benzodiazepines for this, but prefer mag sulfate. Each seizure increases fetal mortality by 10%. This can occur in up to 4 weeks of postpartum, but that's going to be rare. 100 millimeters of blood loss after delivery if there's a postpartum hemorrhage of this. So this occurs within the first 24 hours. It accounts for 25% of obstetric deaths. Management, so we're going to do the fundal massage, which is going to release oxytocin, help with uterine contraction, encourage newborn breastfeeding, administer oxytocin about 10 units per liter, infuse at 20 to 30 drops per minute. Amniotic fluid embolism. Amniotic fluid can enter the maternal circulation during labor, delivery, or immediately after through laceration of the endocervical veins, lower uterine segment, or the uterine veins. It occurs in 6 to 15 per 100,000 deliveries. Maternal mortality rate is high. Signs and symptoms that mimic that of pulmonary embolism, so see Chapter 3 and see Chapter 3 for respiratory airway. So we're going to look at trauma during pregnancy. ABCs first, check our airway, breathing, circulation. Aggressive resuscitation, we got to get in there. After the first trimester, never transport pregnant patients on a flat back. This is going to cause that supine hypotension. What is it called? Supine hypotensive syndrome. Transport on the left side. If spinally immobilized, prop up the right side of the backboard 6 to 12 inches to achieve leftward lean. So we're going to see these stages of labor in the gynecological pregnancy term page. Imminent delivery, regular contractions, 45 to 60 seconds in length at 1 to 10 minute intervals. Intervals are measured from the beginning of one contraction to the beginning of the next. What is the frequency of contractions that we're getting? Contraction that is greater than 5 minutes apart, we want to transport. That means they're not necessarily coming yet. Crowning occurs. Mother has the urge to bear down, sensation of bowel movement. Mother believes that delivery is imminent. Always believe your patient. Don't tell them that they don't know. Crowning occurs. Apply gentle counter pressure to the fetus head, prevents explosive delivery. I remember seeing this. This was a practice test question. So gentle counter pressure to the head. Don't shove it back up. Observe the nuchal cord with the delivery of the head. Grab the head with the hands over the ears to the birth of the head as it rotates for shoulder presentation. Once the shoulder delivers, the rest of the baby will deliver very quickly. Use a dry towel to grasp and support. Suction the airway of the mouth, nose, and open. Only if there is meconium staining present along with signs and symptoms of respiratory distress or coarse gurgling. If the baby's breathing, screaming, crying, let them scream, cry. That's good, son. Dry newborn, record the sex and time of birth. Once the baby is delivered, evaluate it. Cut the umbilical cord. Cord should have stopped pulsating. We don't want to cut it if it's still pulsating. Clamp the cord. If the baby does not need resuscitation, allow 30 seconds to 1 minute after delivery to clamp and cut. 30 seconds to 1 minute. Clamp 4 to 6 inches away from the newborn and in 2 places. Cut between the clamps. Do not take the clamps off. We don't want to start bleeding. So this is our APGAR score, ABGAR. So we have appearance, we have pulse, we have grimace, airway, I believe, and what is our APGAR? Reflex, respiration. Appearance, so not airway, appearance and activity. All right, so we have, let's look at the best case scenario. Active baby, 2 points. Over 100 beats per minute in the pulse, 2 points. Prompt response to stimulation, 2 points. Pink skin completely, 2 points. Vigorous cry, 2 points. That's a good baby. 1 point. Flexed legs and arms. Not completely moving, but they're flexed. So 1 point. Below 100 beats per minute, but they still have a heartbeat, that's going to be 1 point. Minimal response to stimulation, 1 point. Pink and blue, so partially cyanotic, that's going to be 1 point. Slow and irregular respirations, I believe below, I don't know, I want to say 30. They breathe fast. Then everything that's absent. So absent activity, absent pulse, absent respiration, 0 points. If they're completely blue, 0 points. Floppy, just not even flexed, 0 points. So that's our APGAR score. We assign the APGAR score at 1 minute and 5 minutes after birth. Not 5 minutes after the 1 minute, so in total 6 minutes, that's not the case. It's gonna be 1 minute and 5 minutes after birth. So 4 minutes after the first minute. 7 to 9, generally normal, moderately depressed at 4 to 6, 0 to 3, severely depressed. Score of less than 6, you're most likely going to have to resuscitate. Cephalopelvic disproportion. Newborn's head is too large to pass through the birth canal. Oxygen, administration, IV access, and rapid transport. There's shoulder dystocia. Fetal shoulders are wedged against the symphysis pubis, blocking the shoulder delivery. So this is common in 1 in 300 births. Position the patient in the McRoberts maneuver and apply gentle pressure to the suprapubic area. I need my Mac. Rapid transport, breech presentation, the largest portion of the fetus, the head is delivered last. More common in multiple births, do not push. Rapid transport, call assistance, and oxygen administration to consider contraction medication. If we need to give medication to release contractions. Let's try this again. Where's it at? Stand by. No, that's not it. Nope, not that. Stand by me. Umbilical cord prolapse. So the cord is going to pass through the cervix at the time or in advanced fetus. So the cord is compressed against the fetus, diminishing fetal oxygenation from placenta. This is going to occur in 1 to 10 deliveries. Management, assess for cord pulsation. If the pulsating wrap is moist and sterile, dressing and then dry dressing to maintain temperature according to assess for pulse. If not pulsating, insert 2 gloved hands into the vagina and attempt to move the baby off of the cord. May also place mom in knee-chest position. Continue method until the cord begins pulsating and follow the directions above. Nuchal cord. Cord is wrapped around the fetus's neck during delivery. Try to remove the cord from the fetus's neck and during the delivery. If unable, clamp in 2 places and cut immediately. So we're going to try first to remove the cord. If not, we got to clamp it if not breathing. So these are our different levels as far as ages. Just don't even want to read them all off. So we're just going to pick 3. So neonate. The wake rate is 100 to 205 beats per minute. Sleeping rate, 90 to 160. Respiratory rate, 40 to 60. And blood pressure is going to be 80 plus 2 times the age in years. If it's 1 times 2 is 2 plus 80, so 82. I guess that's mean arterial, I don't know. Let's look at adolescent. So wake rate for an average human is 60 to 100. Sleeping rate, 50 to 90. Respiratory rate, 12 to 20. That's in everybody. And then blood pressure is 80 times let's say I'm 30. 30 times 2 is 60 plus 80, 140 blood pressure. So my blood pressure is 140, I guess. So this must be systolic. I don't know what diastolic would be for mean arterial pressure. Because 120 over 80. Yeah. All right, so different drugs that we give. We have adenosine. We're going to give adenosine in 0.1 milligram per kilogram, max 6 milligrams. Get a Mac. I'm fixing my Mac right now, my one from 2008. Let's try again. Come on in. Come on down. Amiodarone. Still back to adenosine. Second dose, we're going to give 0.2 milligrams per kilogram, max of 12 milligrams, just like it would be for an adult. First is going to be 6, then the next is going to be 12. Amiodarone, 5 milligrams per kilogram, max 300 milligrams, just like an adult. So let's say the baby is, 3, what would a baby weigh? If a baby's 10 kilograms, 5 divided by 5 per kilogram, so 5 times 10 is 50 milligrams instead of 300 like we would give an adult. Atropine, 0.02 milligrams per kilogram. Our max dose of atropine is 0.5 milligrams in a single dose. Atropine. I can't even remember. So we're going to speed the heart up, but that's for cardiac arrest. What are these for? Pediatrics. All right. I'm not sure if this is resuscitation or not. I think this is just all the drugs. Yeah, because dextrose, we wouldn't give in resuscitation. So these are just like the random drugs that would happen. So for epinephrine, we're going to give 0.01, not 0.1, as opposed to adults, that would be 1 milligram per kilogram. We're going to max out if it's PEA and asystole or symptomatic bradycardia, then we want to give this 0.01 epi. And we're not going to have amiodarone if that's the case. And then 0.1 milligram per kilogram, 0.1 milliliter per kilogram concentration. There's 2 different doses. I'm not sure when you'd give one or the other. Both are symptomatic bradycardia. One is just 0.1 milligram per milliliter, and one is 1 milligram per milliliter. So it must be the 1 in 10,000 versus 1 in 1,000. This is the first I've seen it as 0.1 milligram per milliliter, and then 1 milligram per milliliter, which is just more confusing ways to look at it. But if that pops up on the test like that, be aware that this is, I don't have to think about that now when I see it on the national. 0.15 junior auto injector. So this is more epinephrine. It's going to be in our junior EpiPen. 0.3 is the adult. As you see, 0.3 milligrams or 0.30 milligrams auto injector max. So that would be an adult dose. 0.25 to 0.5 milliliters racemic solution epinephrine. 2.25% mixed in 3 milliliters normal saline via inhalation. Lidocaine, 1 milligram per kilogram. Magnesium sulfate, 25 to 50 milligrams per kilogram. Naloxone, Narcan, 0.1 milligram per kilogram. Sodium bicarb, 1 milliequilibrium per kilogram. Fluid resuscitation, 10 milliliters per kilogram for neonates if they're less than 1 month, and then 20 if they're greater than 1 month. And let's pause there.